Okay, I think we'll get going. We've got a brilliant panel today, and I know that there's going to be so much discussion, and the hour is going to go really, really quickly. So welcome everybody. I'm going to start with the housekeeping. So just to let you know again that this meeting will be recorded and it'll be available on YouTube in due course. Please do use the chat function to say hi, to make any comments and share any insights that you have along the way. We do have a Q&A function, so do put your questions on the Q&A function if you can, or in the chat. And we are going to have a bit of a, you can put your questions up as you think of them, and we'll have a bit of a session at the end as well. We will be sending out feedback forms, so really do fill them out and let us know how you've experienced the session. And if you are going to be talking about us on social media, please could you use the hashtags ThriveByDesign and LeadsDigi21. Thank you. So without further ado, first of all, I'd like to say a really, really big thank you to the whole panel for taking the time out to come and share your insights and ideas on the importance of ensuring that as we change and transform vital healthcare services that we need in our most vulnerable moments, that we stand true to the purpose and the principles of the NHS, and we ensure that that comprehensive service is available to all. So as we've experienced over the last year, everybody, that digital has played a real key role in our lives in so many different ways, from connecting with friends and family to ordering a repeat prescription. But what happens to the 11 million people who struggle with digital due to inequalities, their life context, digital skills and confidence, and the fact that some digital tools and services are just not accessible? In the last year, we saw a rapid digital transformation of health and care services, and we also saw, sadly, pre-existing inequalities compounded by COVID-19 and also by digital exclusion. And that's why we launched a social change programme that we called Inclusive Digital Transformation. And we went out and we found like-minded people and we went on a bit of a sort of discovery journey, I guess, with them to try and explore how do we co-design inclusion into digital transformation. We worked with West Yorkshire and Harrogate ICS to design a digital and data poverty blueprint. We worked with the NHS Confederation on developing a digital skills guide for the mental health workforce. We worked with Oxford University on what does inclusive remote video consultation looks like. And we're now starting to work with more ICSs around how do you co-design inclusion into different care pathways. So from all of our research, there's lots of areas and lots of organisations who are really interested in digital inclusion and inclusive digital transformation, but only a handful of pioneers who are really doing stuff in this area, and certainly not many areas that are looking at co-designing in partnership with people. So today we've gathered a really amazing panel to explore what does good look like and what does it feel like from many different angles. And I'm really delighted that CBB George's dad, Rob Webster, is here, has agreed to chair the session for two reasons. One, so that I can ask him for George's autograph, and two, because if there's one senior leader that really understands and champions inclusion in healthcare, it's Rob. And we know that we need senior leaders to be on board to make this happen. So without further ado, I'm going to hand over to Rob, who will take us through the rest of the session.
Thanks, Ros. Good morning, everybody. Hello, my name's Rob. I lead the West Yorkshire and Harrogate Health and Care Partnership. It's a real pleasure to be here this morning with this great panel. And thanks to Ros for reminding me that outside of my professional life, most people know me as George's dad, and that's going to get even worse now, as my son's just got a role on CBeebies as a presenter, and first presenter with Down syndrome on CBeebies, which is really great, I think. In terms of today, let me get the panel to introduce themselves, and then I'll say a couple of things I think about this agenda. But I'm going to do them in the order that I can see them. So Kamal, why don't you tell us who you are and why this is important to you?
Hi, morning. Thank you, Rob. So my name's Kamal Bayer. I work in the Bob ICS, which is Buckinghamshire, Oxfordshire and Berkshire West. And this is really important to me from a sort of patient engagement, digital transformation point of view. I come from a primary care background and have always been passionate about making sure that we are accessible for all, really, and have worked with our local health and wellbeing board on leading on patient engagement, and now work in digital transformation as well. So being able to mesh the two is really, really helpful. And I think just going and listening to people, what their challenges are and how we can try and help them. So looking forward to the discussion. Thank you.
Thanks, Kamal. Cleveland, why don't you go next?
Hi, Robin. Hi, everyone. Like everyone else, it's an absolute pleasure to be here. So I'm Cleveland Henry, wearing multiple hats. My first hat, I'm a non-exec director at Leeds and York Partnership Trust, which is a mental health and learning disabilities trust. I'm also group delivery director at EMIS Group, and I'm also a trustee at the Leeds Community Foundation, which is a charity for supporting those most at need. So this is an extremely important subject to me in everything we do, in all my roles, but more importantly, and where I'm really coming from here is in my NED role as the digital lead on the board. It's really important that we are inclusive of how our services affect both mental health and learning disabilities cohort. So yeah, really looking forward to this discussion, and thanks for having me.
Thanks, Cleveland. Pritesh, why don't you go next?
Thanks, Rob. Hi, everyone. So I'm Pritesh Mistry, Policy Fellow at the King's Fund, a health and care think tank. I focus on digital technologies. I'm particularly passionate and interested in this area, I suppose, because I come from a background of being technology enabled, very much focused on engineering, physics and tech. And it's easy to get swept up in the enthusiasm of tech and technology and digital and what's possible. But then in being swept up in that, you forget about all the other people and the implications, and actually that there's a lot of risk involved in that as well. So right now there's big national level initiatives that it feels super important, and there's a real impetus to improve the system. The system isn't perfect, and there's huge potential with digital, but there's also significant risk. So I feel it's absolutely essential that it's inclusive and we improve services overall.
Thanks, Pritesh. Fatima.
Hello everyone, my name's Fatima Khan Shah. I am proud to be a public carer champion who somehow transitioned into an executive leader working in West Yorkshire and Harrogate's Health and Care Partnership. My areas of passion and commitment are empowering people and communities to get the best outcomes possible. That means ensuring that they're as included as possible in the design and delivery of services. And I think that, you know, the digital agenda is a key enabler for that. And another part that is really important to people receiving the best health and care possible is that we consider what matters to them and who matters to them, including unpaid carers, which is another area of passion and expertise. Why do I think digital is important? Well, I've already described two reasons, but I think one of the main things that really attracted me to joining this illustrious party this morning is that I think digital, although it's an enabler, can also be a barrier. And I think if we really want to do this properly, we need to think holistically about how we design and deliver care and services. And in order to do that, we need to consider some of the barriers that people have when it comes to accessing digital. So I'm hoping we consider that today and have some really exciting discussions.
Thanks very much, Fatima. So you can see that we've got a broad range of perspectives, broad range of interests, and you know, some people with some good wisdom and insight. We also want you to be involved as delegates and people involved in the webinar. So you can use the chat function to make comments, ask questions. We'll try and sweep those up as we go along. And Ros is keeping an eye on some of the important ones and some of the really difficult humdingers that are going to get everybody's conversation going. I just wanted to say a few things from a health and care perspective from our partnership, also by way of introduction. I've been in healthcare for about 31 years now. It was my work anniversary a couple of weeks ago, and the world has changed, hasn't it? I mean, I remember I started joined two of my colleagues in a closed office in Russell Square who both smoked, and we didn't have a computer. You know, the mail came round twice a day in a grid, and you commented on hard copies of people's work, and you did that on analysis and statistics and everything. And we're in a very different world now. We're in a fundamentally different world, a fundamentally more connected world, a digital world. And what we need is to make sure that's you know, that's not hidden in plain sight, as sometimes it is for us. So as a partnership in West Yorkshire and Harrogate, we cover about 2.7 million people, and there are a huge number of organisations and institutions involved. So six acute trusts, 4 specialist providers of mental health and learning disability services like Cleveland's. There are 8 councils. There are nearly 400 practices. There are thousands of third sector organisations and businesses, all really working in a system to try and support people and their lives and help people to deliver their potential. And we're connected as a system because we have a single ambition, really, which is to improve outcomes for local people. And in doing that, we recognise that there's 4 aims that we have. We have to address the shocking inequalities that exist in West Yorkshire. You know, if you have a learning disability, you are likely to die 15 to 20 years sooner than somebody who doesn't. Yet having a learning disability is not a health condition. It's shocking, but it's not surprising to any of you on this call to hear that, I know. Similarly, if you're a man with a serious mental illness, you'll die 18.6 years sooner. If you're from a Black or Asian heritage, your access to care will be poorer. You're more likely to be sectioned as a black male. So all these things that we know bedevil of us are something that we need to address, those health inequalities. We also know that there's unwarranted variations in care. The inverse care law persists. The poorest people in our society get the least care when they need the most, because we've designed services that they can't access. Third, you know, we have to put our resources together and use them wisely to make the biggest difference we can. And fourth, you know, investing £5.8 billion every year in the health and care system has social benefit. It has social value. It brings jobs. It's part of the economy. Cleveland's other job with EMIS, you know, that business employs thousands and delivers tech to a significant proportion of the GP practices right across West Yorkshire. So as a partnership, if we're going to deliver those outcomes, focus on inequalities, manage unwarranted variations in care, think about using our resources together wisely and getting these social benefits of all of that investment, all of those jobs, then there's joint work that we need to do. Most of the work that we do is done in someone's house, in their street, in their neighbourhood, in their place, and it might be done across West Yorkshire. But our partnership is built on the fact that everybody in the system is part of the system, and the integrated care system and the partners work together to make the biggest difference that they can. And they might be operating in that level around someone at home, or we might be operating at West Yorkshire and Harrogate level. And we decide to do things together in West Yorkshire and Harrogate where it passes one of 3 tests. Do we have some good practice that we can share? Is this a wicked issue that we want to solve? Because we don't know how to do it, so we have to work it out together. Or is this a scale issue where we have to buy things together or deliver things which are rare? And I would argue that this digital agenda passes all 3 of those tests. And you know, inclusive digital transformation is part of the way we are as a system, because we believe that we're a guest in people's lives and we're not the only ones. So if you think about, I often say to people, if you think that you're just leading in your organisation and that is sufficient, then you are ignoring the fact that you're in a system. And the easiest way to see how that system works is to talk to the families, the patients, the carers who are on the end of the care that you deliver. And what they will tell you often is that they wish you'd talk to each other. They wish you'd share data. They wish you coordinate things. They wish you to tailor things to meet their needs, because at the moment they have a burden of treatment as well as a burden of disease, because they have to coordinate their own care too often, because we haven't understood that we're a guest in their lives and we're not the only ones. So as a partnership, we've got some huge ambitions. They're set out in our 5-year plan, which was published just before the pandemic. They're about, addressing health inequalities for people with a learning disability and serious mental illness, turning the curve on childhood poverty, reducing the 22-year gap there is in healthy life expectancy for people in West Yorkshire, making sure that maternal mortality is reduced, suicides are reduced, that cancer, early presentation of cancer is increased, and that antimicrobial resistance is resolved, that we have a representative leadership that looks like the communities that we serve, that the economy provides good jobs, which drives good health, and that we recognise that if we don't get on top of the green agenda, things are going to turn out very badly for all of us. So in that spirit, our plans are driving forward, I think, improvements in care, which are targeted at the people who need the most care but get the least. And 3 quick examples of that. We're a trauma-informed system working with the West Yorkshire Violence Reduction Unit to look at, how do we make sure that people understand the circumstances which got people to where they are in their lives now, and what does that mean in terms of the way that we deliver care? Because people with multiple needs, often driven by child sexual exploitation, violence, abuse, and other issues, need a different offer. Second, when it became clear that people from Black and Asian communities were disproportionately impacted by COVID, we did a big review with Professor Dame Donna Kinnair into, are we doing enough ourselves to address this? She came back and said, you're doing lots of great stuff, but there's more you need to do on housing, education, employment, stigma around mental health in some of our communities, the way we commission services, and on leadership. And shot through all of those is a need to communicate and engage differently using digital tools. And third, people with learning disability 8 times more likely to die of COVID, already diagnostically overshadowed and can die of preventable illness more than you or I. So we've prioritised treatment of people with learning disability, digitised their VIP passports so everyone can see them, shared data and information to make sure they can get their vaccines and their carers can too. So this is real work for us. And what I would say is over the next period, what we've got is the legacy of all of the work that we wanted to do prior to the pandemic, which is about multimorbidity, health inequalities, poor access for some of our communities, which has just got really a lot harder because those are the people who've been most impacted by COVID and the economic downturn. And we've also got an old foe that's come back. I call it double trouble. So we had this trouble already with the health inequalities and multimorbidity. We've now got waiting times back. The worst waiting times for a generation. And I was really proud to be part of a generation that got rid of waiting in the NHS. That got rid of the joke that we had, care was good, but it took years to get. Unfortunately, we're now back in the position where people are waiting too long. So this double trouble that we have to deal with over the next period needs to be done in a way which uses digital technology, which makes sure that we don't simply replace the things that we did before with a digital version and expect it to be better, where we use digital to address both problems that we have around multimorbidity, inequality, and access, because I think that we can. So let's get into the conversation around that a little bit. So I'm going to ask Pritesh, from a kind of King's Fund policy perspective, where do you think this is in the policy agenda? And are there any policies that are really going to help us drive this in our systems?
Thanks, Rob. Really good question. So as you mentioned, the integrated care systems, I suppose, are one of the biggest things that are happening within the NHS kind of structurally in the changes of the NHS. So England's going to be, well, there's going to be 42 areas created across England that are going to be ICSs. That there's a bill going through Parliament currently, so they're going to be legally enforced structures, and with that comes some duties. And as you kind of mentioned, one of the core purposes of integrated care systems is to tackle inequalities. So they're being set up to coordinate, plan, and create strategies around the healthcare system for that particular population. So it is great to see inequalities actually within the legislation, within the ICSs, the integrated care systems, and they're going to have a duty to create those integrated services that reduce inequalities in access and outcomes. So again, fantastic. And it's really promising to see that the integrated care system should also engage with those impacted by the services. Again, so that's within the legislation. But it's not as high a bar as I'd like to see personally. I think it's a bit of a catch-all. It mentions consulted, it mentions informed, it doesn't mention co-development, so they could go further. That is I suppose, at the highest level of legislation and structure change. But there's also a number of different strategies and guidance documents have been released recently, and I'll touch on a couple now. So there's the What Good Looks Like framework, which was released a couple of weeks ago, which aims to define what good digitally enabled health and care looks like. And it's got one particular section, I think section 5, on empower citizens, which stipulates that integrated care systems should have digital inclusion strategies for digitally disempowered. So there's a lot to unpack in some of that terminology, and I think that could be interpreted different ways. The framework itself is quite high level. It makes a really good vision, but the nuts and bolts of getting there will rely on people within the system sharing knowledge. There's also an expectation that a good digitally enabled health and care system engages with citizens through co-development to create citizen-facing digital services. Again, I mean, that's fantastic, all moving in the right direction, but again, the nuts and bolts of getting there is missing, and the guidance will need to be kind of created, as well as the networks to kind of, and the peer support. The other bit of guidance I'd like to just briefly mention now is the data and digital strategy, which sets the future for the use of data and digital within the NHS. There is some mention around inclusion and inequalities, particularly focusing around research, harnessing data for service improvement, but unfortunately it misses out on the engagement, the co-development, and especially the trust aspects. So I think that's particularly important within the data arena. If we reflect on the GP for data research and planning provision, which I suppose if you read the Daily Mail, it's been called the GP data grab. And so that was what felt like a rushed change to how GP data is captured and utilized within the healthcare system and within broader service provision. And due to the way that it's communicated, some of the changes within that approach, we've seen what I think is a substantial increase in people opting out of sharing data. So more than 5% of people are sharing data, and that's going to have most likely some demographic variation as well. So within that, it'll probably accumulate, particularly within people who have more mistrust with the system. And if we look at the vaccine hesitancy work that's happening on the ground, engaging with community leaders, it's fantastic, some of that work that's happening, actually reaching into communities, connecting, building trust, and that's the learning that we need to bring into how GP data for research and plan purposes and how we approach data needs to change within the healthcare care system. And my last point, I suppose, is around training, leadership, and culture change. Often I think people expect me to talk about technology when I talk more about the system and the culture and the enablers. And really, we are, as I kind of alluded to, missing some of that real support to enable some of this to happen, the co-development, the skills that enables that, the citizens' deliberation, the listening skills that need to be just the fabric of what we do. Thanks, Rob.
Thanks very much, Pritesh. Some really powerful points there. So we've got a good framework, we've got legislation, we've got ICSs, we've got the What Good Looks Like framework, we've got the data and digital strategy. these cultural points that you make, I think, are really pertinent. So I wondered if I'm going to bring Fatima and Kamal in here. So Fatima, you lead on personalisation in West Yorkshire Harrogate. What do you think about these cultural barriers? What do we need to do to make people see that it's not enough just to do something, ask people if they like it?
I mean, there's something about, as Patricia alluded to, supporting people with the skill set to facilitate the change. It is scary, isn't it, from a workforce perspective, of starting this conversation, you know, taking the power and giving it back to communities. That can feel uncomfortable to people, which is totally understandable. But actually, if you do it correctly, it can lead to some of the most creative and innovative changes, which can transform the outcomes of the people, which for me is a compelling case for change. And in order to do that, you've got to focus on the needs of those individuals rather than what your need is. So that means when you're having the conversation, you do it via a variety of mechanisms rather than a one-size-fits-all approach, that you take the conversation to the individuals rather than waiting for them to come to you, because quite frankly, why would they? And also, you know, when you are having those conversations, as Patricia alluded to, trust is crucial. It's crucial to all the elements of when it comes to sharing information, when it comes to developing these processes. You've got to do it via the right influences. I wouldn't use the term community leaders. Sometimes people find that terminology uncomfortable. I personally don't believe anyone leads my community. I can talk for myself quite clearly. But I think there is something about utilising people that have influence and trust in communities to amplify the messages and to facilitate those conversations. And I think they're crucial. But I think personalised care is all about, you know, giving people the skills and expertise to develop their own solutions. And that means we come to them with no proposed answers. And that's scary, isn't it? You know, it took me quite a while to sit there and go, I don't have all the solutions. Come and tell me what you think we should do. That felt really uncomfortable at first because I felt like a bit of an idiot. But actually, I didn't need to. What I was bringing to the party was the facilitation and the enabling, which for me was far more powerful. And going in there with that approach meant that I could understand what matters to those people, what motivates them and what the barriers were. And it just felt like a really balanced conversation. And also, I think the final thing I'd say in answer to your question, Rob, is that, you know, it isn't just something that people who work in the digital area should be doing on their own. Like you say, I lead personalised care. We've got a whole range of expertise and we're always there to collaborate and facilitate these conversations. So I think there's something about us, you know, really being open about the fact that we want to do this together and be really radical and brave about it, which is totally how we operate in West Yorkshire and Harrogate.
Yeah, not to, you know, you wouldn't say this yourself, but it's pretty clear from feedback from the national team that the work that you've done as a result is amongst the best in the country. So if you engage people in co-producing the issues as well as the solution, actually it seems to work. But I think what you're saying is it takes a bit of courage, personal courage, to do that, and courage probably from the individuals who are coming to talk to you too. Kamal, what do you think? What have you done around the culture in Bob to make this work better?
Yeah, I was just reflecting on what Patricia and Fatima was saying, really. And I think the framework's all well and good. And, you know, with any policy, you can flex it as much or as little as you want. And, you know, and I think this panel's probably representative of people that personally find this subject, you know, something that they're passionate about. So therefore, in their day job, they're going to be going that extra mile to make sure it happens. And so I was just reflecting on how do we make sure that that is in everybody's mind rather than those of us who are actually feeling that this is an important thing. And if I just give you a small example. So I ran a workshop in June on behalf of our ICS with patient leaders, with voluntary groups, community groups, with people working within our communities already, faith leaders, anybody really who is working with the general public or with our citizens and our patients. Because I think we all know what happened during COVID, and I don't need to go through it again, but I think some of that sort of cultural revolution that happened then was phenomenal. I mean, some of the change that we've been wanting to make in digital happened overnight, not necessarily in the best way, but it happened overnight. And so one of our things was thinking about recovery and thinking about, well, how do we make sure that we capture what has already been done, but build on it so that we build back better. And so internally, I kept trying to sort of lobby to remind everyone that although we've got the digital transformation agenda on our minds and we think digital inclusion's important, all of these groups, all of these individuals have been out there working with our, patients, with our residents, with our citizens. Let's go and talk to them and find out what they've done. Let's share some of that practice, because we don't have all the answers. We're sitting far too detached from it. And thankfully, I still have some patient contact with some of the groups that I sit in. And so I hear what the person who's, caring for somebody living with dementia, I hear what they're telling me. I hear what the person who's attending the Learning Disabilities Partnership Forum is telling me. And, and I think that is what drives me to want to then take that back and go, okay, we need to change this. We need to change this. And so that was part of the reasoning behind the workshop, thinking, well, let's start with people who are working with people. Let's make sure we're all on the same page. Let's share some of those resources. But I think also it's about embedding it. So as Fatima said, we've got people all over the organization who are passionate about it. So it shouldn't be down to digital or the engagement team or the comms team. It should be everyone. And I think if we start with an organizational perspective where those people who think this is important step forward and come and help us, so many people will step forward. And I think we need to start within organizations before we go outside and say, oh, actually, we need to do that. And I think, majority of people working in this kind of sector do it because they want to make a difference. They don't do it for the money, certainly. And so I just think there is a bit of a social movement that we need to make within before we go outside. So I think, and I totally agree with Fatima. I went to the workshop with the bare bones of a framework for the ICS, for the strategy, because I wanted to co-produce it. But boy, did I get some hassle that I didn't have one ready for them to view. So it is scary.
I think it's scary. It's kind of that thing of, so I think what you're describing, Kamal, is really linked to a new style of leadership. Anne Cooper's talked about this in the chat. It's a bit of humility. I don't know all the answers. Why would I? I'm not sitting in someone's house in Chapeltown today. I don't know what the position is for them today. I don't know what the solutions for them are. But we can facilitate those conversations with the people who might know, including the individuals themselves. But that takes a different type of leadership. But it also takes people to have some responsibility. And I know that Fatima took a paper to the NHS Assembly last week with Chris Ham about, what would a new relationship with the public look like, which embodied a lot of these thoughts. And I guess if we look at the really nice work that the Richmond group of charities did on what does a good ICS look like from the public's perspective, and if we look at the people plan for the NHS and care system, which talks about a sense of belonging, more staff working differently in a compassionate culture and they feel like they belong. There's a lot of sort of synergies here. There's a lot of things that tie this together. Cleveland, I mean, you've got multiple roles, and you can see this from several perspectives. From your job in EMIS, where do you think the industry stands on this at the moment? Is this something that's discussed at all, or is it something that they feel is like many NHS organisations feels like it's something in a parallel universe?
From putting my industry hat on, absolutely, this is a key and very important subject for us, because look, we're a commercial organisation that delivers health technology and have done for over 30 years. When we talk about co-design and the rest, I'd like to say we invented it. But EMIS, when it started 31 years ago, when I started my career after studying, was all about designing a solution for doctors by doctors. It was actually created by those individuals that were sat in GP surgeries and needed to find a better way of being able to administer patient records. That was the simple need. And that thread has continued throughout what we do. You know, we talk about, you know, the inclusion and the rest that everyone's talked about. And I'd say industry also needs to be part of that subject, because, you know, they do have knowledge and experience on what can be delivered through technology, you know, the boundaries or otherwise. And often, actually, what industry gets at an organization like my organization is an instruction on doing it to a specific specification, as opposed to saying, this is the challenge, how can you help us answer that? Because we do have experience and knowledge, and I'm not just my own organization, you know, the health tech, the digital health industry, there's lots of knowledge, insight, information and expertise that should, in my view, be included. But, you know, this whole period has been really, really interesting. If you look at, you know, clearly from last March, you know, you'll hear people in organizations that work in digital healthcare and said, it's been amazing. You know, we've seen, you know, 10 years of adoption and movement in a matter of months, and all that's been really, really great. You know, the move to online consultations and all that sort of good stuff was absolutely brilliant, and I think we have to be really, really proud of that, but also really, really careful of that. You know, with my other hat at my NED at Leeds and York, and studies that I've seen, we immediately saw a decrease in the number of contacts for mental health conditions. You know, so as much as, you know, the great technology was there, you know, of course you can get in to see your doctor and you can see and have your consultation, but absolutely certain areas started to see a decrease. And as we reset and recover, it's really important that we understand and assess that, and I think it was Fatima or Kamal said it earlier, one size doesn't fit all. We've got to find the services where digital does work and where digital doesn't work, in order to provide the services to the patients and service users out there. You know, but the technology industry they've been banging the drum for many, many years. They've been delivering lots of technology. I mean, just in mental health alone, there are over 20,000 available mobile apps right at this moment. So there's lots of stuff out there. Many of them have got evidence of efficacy, many haven't, and not all have been designed to be inclusive, and that for me is concerning. So in the industry, yes, most of us, and I'd like hope that all of us talk about it. It's part of what we do, but also that it's also important that we are part of the discussion on what we need to do going forward.
Thank you. I mean, it's one of the things that strikes me is that, you know, are we trying to control an uncontrollable situation with tech? Because there are so many things that we could use tech for in people's lives, which are beyond, you know, our imaginations. I was always struck by, you know, the fact that you've got people who use Google Maps to tell them, to guide them. You know, you've got people like Molly, who's got Usher syndrome, Molly Watt, who'll say, well, you know, the best thing's ever happened to me is I got some hearing aids which allowed me to have some kind of direction, and attached to my Apple Watch, which could then attach to my phone, which meant that, you know, when you get Google Maps, it says take 10 steps forward, then turn left in 5 yards. That's telling me where to go. Because the guide doesn't know where I'm going. You know, it helps in certain situations. It's never been there before. But people didn't say, well, we're going to use Google Maps and apps that are freely available to support her in her life. So how do we get to that kind of, there are so many things that we could embrace that would help people's lives that we just have to facilitate. It's about creating the context, creating the environment, rather than saying, you know, here's a set-top box that you can use, which you must use in this kind of way. I know we've moved on from that thinking anyway, but you know, is this something what kind of approach do we need to take? Is this about facilitating a context, or is it about giving people specific tools, or is it about both? This is a question to anybody. Fatima.
So I'm a simple woman. I think it's a mixture of both and where it adds value. So for example, in personalised care, we have, you know, 3 areas of focus, as you know, Rob: supported self-management, shared decision-making, social prescribing. Particularly for supported self-management, digital can enable so much. You know, you've got apps like Brain in Hand, you've got My COPD, you've got NHS at Home, which can transform lives for individuals who want to manage their own self-care. Then you've got the other elements of, if you're providing care and support to somebody and you don't live with them, some of the digital elements that can support somebody, you know, to know whether they've had their medicine, you know, whether they've fallen over, whether they put the kettle on to make a cup of tea. If we facilitate and enable and empower people with the knowledge that this is possible, it can absolutely transform the way in which we approach the delivery of care, but also their experience of care. So I think it's a mixture of the two, but it's also about keeping it as simple as possible and not having this must be the way it needs to be, because, you know, we are a society that is used to choice. So, you know, and you know this from me personally, Rob, someone tells me this is the way it has to be, I immediately question it and go, why? So we just need to give people a range of options and then empower them to make the choice, which is all about what personalised is. And if you if you tailor the care to the individual, by default, you will mitigate any inequality they experience. So for me, it's a win-win situation.
Okay. Any other thoughts? I mean, it's all right having the apps, but if you don't have the data or the kit, or or English isn't your first language, what are you going to do?
Yeah, and you know, I agree with what Fatima said there, in particular about keeping it simple. I think it's assessing the need and then identifying the appropriate delivery pattern for that to work. You know, this one size fits all, you know, it must be this, it must be that. We've got to get away from that. We've really got to open our thinking and look at, as I say, you know, really assess the need and try and then work out, either give the individual options or assist them in understanding the options, what is good and what is not, what works, what doesn't work. You know, it goes back to that whole thing around, you know, co-design. You know, we can use that in so many. An individual needs to have either assistance or support in co-designing their correct pathway, and you know, whether that's through digital or not. We've got, you know, for me, you know, even as a techie of 30 years in technology, it's really key that it's not just digital is the answer, you know.
Yeah.
It isn't always. We've got to get that right, or else we're going to make it worse.
And we know that, you know, so people often jump to conclusions. For example, work we've done in Wakefield suggests children want face-to-face care. But the narrative is, oh, well, the kids want digital. Well, actually, they want face-to-face care for some things. Kamal, have you got a thought on this one?
Yeah, I was just thinking about the, you know, what do we do first, and what's the you know, the situation with the one size fits all. And I was at a learning disability meeting last week, and they were saying to me, oh, can we have explanation in easy read, and can we have things that are simpler? And we were talking specifically about GP websites there. And I've been doing a lot of work with our providers, trying to look at the information we're providing for those living with learning disabilities and those people caring for them, whether that's family, loved ones, or carers. And the sort of general consensus in the room is, why can't we do everything in easy read? Why do we have to have things that are complicated for everyone? And so a little bit of the one size fits all there. I think maybe we need to think about how we deploy things, how we're reaching out, how we're sharing information. And I think Pritesh touched on it earlier with the GP data for research and planning. Now, having worked in primary care and worked with my patient groups and tried to convince them about, you know, this is what's important, this is what isn't important, but it's your decision at the end of the day if you share your data. I just think we've lost so many opportunities there about having that conversation in a transparent way that builds on relationships that we had previously, because we bypassed every system. If we are doing the bottom, you know, the top-down approach, then we need to open channels of communication that are open, that people can feed in. So nationally, that's my push. Make sure you're open and you listen, or leave it to people who are doing it locally, who have that insight, that knowledge, and are able to then drive the agenda. So yeah, I was a bit frustrated with that, to say the very least. The email came into me at 5 o'clock on a Friday afternoon, just as my computer was being upgraded, so I had no contact, so I was on a telephone. That was it. So it's just typical, isn't it?
So one of the most powerful things that you've all talked about is trust, and we should remind ourselves that, you know, the most trusted professions in this country are nurses first, and then doctors, GPs, and that's people will. You know, I've been out with clinical staff to people's homes, and they do not buy new pajamas because you're coming round. They do not, you know, tidy up because you're coming around. You see people how they live today because they trust you. They trust you at the end of their lives. They trust you with their newborns. They trust you at the worst possible times. And they trust you to be discreet. And I think we've got to retain that in all that we do. And that means being open and honest about what we're doing all of the time, and not raising any sort of criticism or cynicism around what we might be doing. I want to talk about equalities, but I can see Ros wants to ask a question.
Well, I was going to challenge what you just said a little bit, actually, because I think, as we know from the Mori polls and all the rest of it, that nurses and doctors are the most trusted professions and so on. But I think also, I absolutely agree with this whole thing about trust. And I was in a session the other day where they were talking about progress at the speed of trust. And I think that's the key to really good, authentic co-design. And that's the key to actually building the system that will support everybody. But there also is, you know, there's people who are not even getting services, people who are really, really far away from services, and there is a lack of trust there. And I think what we need to do is, there's a solution as well in integrated care partnerships, in that it includes the voluntary sector, it includes community groups at its best, and so it's a mixture of both. I think if we can tap into the trust that there is in terms of clinicians, and the trust that there is with amongst community people. And I loved how you described, you know, how we connect with communities. Fatima, I thought was a brilliant sort of description. But if we can do both of those things together, then we're going to get somewhere, aren't we? Then we're going to be able to, and that there's an importance about being honest as well, about, you know, what resources we do have, you know, what we can achieve together, and also honesty about where the system's at right now. And I get really worried sometimes. I sit there and I think, you know, I'm an advocate for digital, but and I don't think we can live without it in the future. It has got a bad name sometimes. A lot of the research we come up with, people think that a digital service is worse than a face-to-face one, and it's not always. You know, you can get some really good quality stuff, so there's a brand issue there as well. But there's no doubt about it, digital is part of our future. And if we leave behind those 11 million people, we're leaving behind the people who need healthcare services the most. So we have to work hard as systems together, and we have to tap into every resource, every, you know, asset that we've got to do that, because it's not easy, it's not going to be easy.
So well said, Ros. And I think it brings us into something I want to ask all the panel, really, which is, if we look at other industries, you know, there's all of the issues around safety, the safety industry modelling itself on men. You know, so everything's designed around a male physique, and in some ways, I think often in health and care, we design services sometimes too often where one size fits all. And as I said, we've got double trouble at the moment. So all of the issues that we had around inequalities, people who find it difficult to access services, people living in deprivation and poverty, people with learning disability, people with serious mental illness. This is going to get worse for the whole system as we move forward. And many of these communities won't have the tools or the access to engage digitally. So what's it going to take for us to make sure that this time, those are the very communities who are helping us to co-produce the solutions? Pritesh, is there any kind of national evidence or great practice that the King's Fund have unearthed in this area?
It's a great question, Rob. So there's a few different things that are going through my head. I mentioned that the legislation, the focus on inequalities. There's also the primary care networks that we set up a few years ago that are going to have, I've forgotten what this stands for, DES, enhanced service specifications, basically a contract that is around inequalities and improving the inequalities at a very local level for their 10 to 30,000 populations that they serve. So there are things happening at a kind of national level that should be able to support some of that inequalities, but a lot of it is, you know, the building on the good work that's already happened with the vaccine deliveries, the work that people like Fatima are doing, and learning from that. How do we bring each other together to share learning, to give each other support in doing that, especially in this time where there's such a limited capacity. There's so many people that need help, but we also need space to create the services of the future, and there's huge pressure to do both. Yeah.
So Myron Rogers, who's informed a lot of our thinking locally, says, you know, the process you use to get the service will dictate the service that you get. So if it's kind of inclusive process, you'll have an inclusive service. If it's kind of me deciding, you get one that excludes everybody. Other thoughts on this, because it seems to me it's the critical issue. You know, how do you co-produce things with people who find it difficult to engage with you?
I think for me, Rob, you nailed the point there when you said you go and visit someone's house and, you know, they don't get a new set of pajamas and they don't tidy the house up. It's those individuals that we need to be involved with to understand, to co-design with them. You know, we talk about inequalities, and, you know, we've had we already knew it was there, but COVID brought us the biggest kicker that we've all haven't probably needed in order for us to get serious about the inequalities that are out there. And we need to then use that as an opportunity to work with those individuals. We need to be, you know, stop dictating, stop saying what we believe is going to be the right thing because it's going to work for the masses. We need to get into those homes. We need to get into those individuals. We need to work with individuals across completely different social demographics, areas, languages, age. You know, my 86-year-old mother will never feel comfortable with a video consultation. Don't care how great I tell her it can be, and, you know, she can see the doctor in 30 minutes or 3 weeks. She'll wait 3 weeks.
Yeah.
You know, so we've got to go and work with those individuals to help us design what the service should and could be. That's my view.
Well, I can see you want to come in.
Yeah, I mean, Cleveland, your mother doesn't have to engage with video. She should still be able to telephone, and therefore the doctors should be able to deal with them in a different way. And I think, you know, Anne's put something in the chat about it. We have got this double jeopardy situation where there isn't enough capacity. And, you know, and I touched on it earlier, we are all passionate, so we're going to go the extra mile to make sure in everything that we do that we're trying to engage, that we're trying to talk and co-produce and do all of that. But I have equally got colleagues who, you know, when I was trying to organize a patient engagement event in September, who said to me, just do a survey instead. And just that one statement crushes me so much, because I just feel like you really haven't got a clue. And so then how do I ensure that colleagues of mine who are saying things like that get a clue?
Yeah.
Sorry to be controversial, but I can't deal with that, because I just think, where does that come from? Should that be nationally driven? Is that about leadership? Is that about the system? Is that about the framework? Is everything? we never have enough people. So it's about trying to make sure we prioritize this, which is important.
So for all the panelists, we've only got 4 minutes left. So I'm going to ask you to do something, which is just tell me one thing you'd ask the national system to do for you, and one thing that, as a digital enthusiast, you want from others in your system. And I'm going to ask Fatima the question. So Fatima, you're going to set the tone on this by being really, really concise. So one thing from the national team and one thing that you want others to do in the system.
Give us the power to do things the way that is right for West Yorkshire and Harrogate. So let us design and deliver it in the way that we see fit, because we know our populations and we can deliver it in a way that's meaningful to them. Is that concise enough?
Brilliant, yeah. And what would you want from others in the system?
I want others in the system to be brave. I see opportunities. I know we've talked about double jeopardy, but I think this is an opportunity for us to be really radical. I think it's given us the push for change. So I want us all to pull together and realise the potential of this, but also be really brave about trusting each other to lead different elements, really embody distributed leadership.
Thank you. Pritesh, you next.
So from a national level, I'd say, leaning into what Fatima mentioned before, allow people to gather and take control of what they want from the system, see the power, and embrace the uncertainty that comes with turning up and listening and trying to understand what people need. And from the system, I suppose I'd ask that everyone gives it a bit of time, a bit of headspace, and approach this without preconceptions.
Thanks, that's perfect. Cleveland.
Well, that's a difficult question. Get the healthcare digital industry involved in the conversation, not just tell us what you want us to give you. Get us involved. We've got ideas, thoughts, experience, knowledge, and ability to make a difference in this.
And is that, so that's for national and local then, given the...
Absolutely.
Yeah, fantastic, thank you. Kamal?
So I like what Cleveland just said as well. But I think in terms of nationally, I think the policy needs to allow local systems to define their own, but there needs to be a minimum standard, because otherwise you will have some areas who won't even reach that minimum standard. So there's something about being accountable and having responsibility. And I think from local systems, I would say look for local champions, because if you've got somebody who's amazing as Fatima, go and give them that platform so that they can go and deliver it.
Thanks, Kamal. So let me just summarise a few points, I think, of what we've heard in the last hour. So firstly, I think Pritesh reminded us that there's an infrastructure, but this is a cultural challenge. And we've heard that this is a leadership issue for all of us, that we need leaders with the humility to say, I don't know what the issues really are for you. I trust that you're making rational choices based on the life that you're leading. So tell me what the issues are and let's try and work on the solutions together. So that kind of humility and courage to have those uncomfortable conversations is something that's an act of leadership. The national standards are important, and being able to get to basic investment and minima across the country is important, and a national framework is important, but it's got to be locally delivered and locally flavoured, and that local flavour needs to go right down to the individual. That we've got an asymmetry here of what I call the tyranny of the average. So great, 90% of people are being vaccinated, fantastic. What about people from a Black Caribbean background? Well, it's not 90%. Well, what about the likelihood of people from Black Caribbean background dying of COVID? Well, it's higher. Okay, so we've got a problem then. So how do we want to move away from the tyranny of the average and see the diversity and see the person? And that requires us to think about how we're all working with that person. We need to work with the industry, and that has benefits for the industry and it has benefits for us. 22% of UK health tech jobs are in the West Yorkshire Leeds City region. This is an economic opportunity if we want to take it, as well as changing people's lives. And I think ultimately we need to just connect more of the system to itself. You know, we've got Thrive by Design here in West Yorkshire. We've got NHS Digital here in West Yorkshire. We've got universities here in West Yorkshire, got industries here in West Yorkshire. We're a partnership of the NHS, local government communities and the third sector. If we connect that up, we've potentially got a chance, because this agenda is about digital, but moreover, it's about people and it's about inclusion and it's about, you know, co-production of the digital solutions with an overall offer for people around their health and care. So it's been a brilliant conversation. We could have kept going for hours with there's more questions and comments here, but I hope people found that useful. Back to you, Ross, for any final thoughts.
Yeah, thank you so much for that. That was absolutely brilliant. And there was, you know, like you say, we could have gone all day, I think, talking about that. And I hope that we do get an opportunity to have this conversation further as well. Some brilliant points. Thank you so much for all your time to contribute. And also thank you for all the comments and questions in the chat. There's been some really good points being made, so we'll capture that. And with that, I think that we should let everybody go, because we're just about on, well, just slightly over time. Thank you so much, everyone. Take care.